Now I'm going to introduce our next expert panelist. Dr. Bernadette Boden-Albala is the director and the founding dean of the University of California, Irvine's Future School of Population and Public Health.
Thanks so much, Dr. Manley. And next slide, please. So, as has already been previously mentioned, CNS really comes late to the table in terms of understanding the social and structural constructs of neurological diseases. And if you think about some of the reasons why this may be, early studies were primarily done around CNS disorders in white populations and really focused on biological risk factors. And there was a whole notion, I think, that most of the neurological diseases really arose from genetic origins. And I remember coming in to doing stroke work as a stroke epidemiologist in the late 1990s. And there was this whole big list of what was not modifiable for stroke and a very small list of what was modifiable. And thinking about the non-modifiable: age, race, ethnicity, gender, and a lot of the biological variables, we've really made this shift over the last 20 years to start to think about these risk factors in terms of modifiable and what was the impact of sort of the social and structural environment on them. And the last thing I think is that when we're thinking about central nervous system diseases, we're really thinking about sort of a real heterogeneity in diseases and risk factors. And this may be one of the reasons why we were, again, late to the table. And so it isn't until the late 1990s, early 2000s that we move from just associations that are related to access in terms of education, in terms of wealth and income, and really start to look at what the life course impact is on, and when those impacts take place, thinking again around the life course, with the end, of course, being some of these neurological diseases. And so what you see in front of you, though, is 20 years worth of thinking through what are these sort of determinants of inequities in neurological diseases. And this comes out of a very recent discussion and supplement that's coming out in neurology. And this was work that Richard Benson at NINDS really brought a whole group together to look at. And this is really one of our first models or adaptations. And how do we think about the social environment and the structural environment, thinking about primary fundamental causes of disease and working our way through. And I'll just bring your attention to the third column: intermediate determinants of health inequities. And there we have the built and natural environment, and thinking about everything from food availability to pollution to transportation to structural barriers to community resources. Next slide, please. And so if we then look at how place matters in CNS disorders and where we are, and we've spent a long time describing inequities. We spent a lot less time understanding mechanisms, has been alluded to by our first presenter. And we are taking some time now to think about what these interventions would look like. But thinking about the heterogeneity of diseases, thinking about stroke, epilepsy, and Alzheimer's, we see that when it comes to environmental risk factors, for stroke, for example, we see everything from now reported risk associated with stroke impact around particulate matter in air, around noise pollution, around temperature, around things like neighborhood level cohesion, the collective efficacy of a neighborhood. And that probably impacts in some way stroke related to what is accessible in the neighborhood, walkability, green space, and even things like recent data coming out that redlining, historical redlining, is associated with increased stroke prevalence. And the same kind of work is now being done. Epilepsy is really late to the field, but thinking about more environmental environmental exposures, as well as socioeconomic exposures, and Alzheimer's disease sort of in between in terms of what we're thinking about. But again, our particulate matter, social cohesion, green space, all of that. Next slide, please. And so when we think about directions for interventions, clearly identifying and really addressing structural barriers is key. Thinking about redlining practices and the impact of those now, even though a lot of that was historical. Thinking about ways that we can tear down structural barriers. The New England Journal of Medicine, over the last year has said, if you're doing trials, you really need to think about inclusion, and we're not accepting publications where you're not talking about understanding what populations you're looking at. Engaging in meaningful partnerships with community. In a recent scoping review of community engagement for neurological diseases, we found that most of the community engagement was really very little and not meaningful, and only was engagement by PIs around things like translation of services and some partnering with community organizations and community boards. But really we need to think about including principles of CBPR, having communities advocate for themselves and really think about all of these structural environmental barriers. And then finally, thinking about designing innovative interventions, thinking about interventions around family or larger networks or different caregiver models, community health worker models, multidisciplinary teams, getting out of just thinking about biological risk factors and using only folks who are in the medical field, but really thinking about civil engineers and gardeners and industry as partners. And then finally, focusing really on life course interventions, trying to get into and make changes earlier in disease states, in sort of pre-disease and the biomarker state, and really focused on prevention and adaptation. Thank you.
Thank you, Dr. Bowden Albala.